So we had a very nice discussion about one of the most critical points. We know today that stem cell transplantation is the only curative option we have for patients with myelofibrosis. That's point number one. And we know from the literature that from 10 to 30% of the patients who receive stem cell transplant can relapse. And in general, this event occurs in the first 7 months after stem cell transplantation, and the overall survival of these patients is about 2 years. So it is quite important to have a strategy. And the best strategy to improve survival for those patients who follow stem cell transplantation is to have a strategy of control and monitor of mutations. So it's quite important to have an assessment, a quantification of the VAF of JEC2, CALR, and MPL. And we have to monitor our patient at day 30, 100, 180, and 1 year. So this is quite important because if we capture the molecular relapse, it's a better option for patients to achieve a new molecular response and a better survival. And then, of course, what can we do? We, of course, for those patients with no GVHD, we can do a weaning of immune suppressed therapy if the patient is still on suppressant therapy. That's the point number one. This must be very careful because GVHD may reappear, and so we have to follow this patient very carefully. Option number two is DLI. And DLI, again, is a choice for those patients without GVHD. And we have to do DLI, and after 6 weeks to monitor the patient and say if GVHD occur, no way to a second DLI. If GVHD does not occur, we have to choose if the patient is in remission, no need of DLI. If the patient is not in remission, need of a second DLI. And in general, patient can obtain a molecular remission in 60-70%, depend by the casuistic of the patients, and so DLI is effective. And when also this procedure is not indicated or fail, we can consider the second stem cell transplantation. And in a general EBMT observation, about 30% of the patients who receive the first stem cell transplant and fail receive the second stem cell transplant. And again, this is an option for not all patients, 30% is not all, and of course it's an option for patients with a good performance status. And then if we failed any cellular therapy, we can consider azacitidine, for instance, hypomethylating agent or interferons that can increase the rate of GVL. And this is, of course, an option for some patients. And if all of these things fail, we have to consider to restart the JAK inhibitor, so ruxolitinib, momelotinib, or fedratinib. And we have to tailor the decision around the patient profile. So if the patient presents mainly with anemia, momelotinib is probably the best choice. If the patient presents with symptomatology and excess splenomegaly, ruxolitinib or fedratinib may be an alternative option. But of course, we have many clinical trials. We have in the process to start phase 1 study with mutant-specific drugs, and we are in the doing some phase 1 study with antibody, again mutant CALR, and we will start very soon also bispecific again mutant CALR. But we know that for the time being, in general, clinical trials exclude patients who receive stem cell transplantation. The only one currently active is the bispecific against CALR mutated. So we have to consider this in our decision, in our model of decision.